with no more ado, I will start my introduction. So welcome, Louise. Thank you very much for joining us this evening. We were speaking before about the fact that we hoped to be able to have this talk at the Brilsey itself, but unfortunately there were very few people who wanted to attend the Brilsey. So rather than have the whole place open and do it like that, we decided to go for another Zoom meeting. This talk will be available via our YouTube site in about a month or so's time. I think that's everything that I've got to say as background. I'll now just introduce Louise. So Louise has been at Bath for what seems like a very long time. She did her undergraduate studies at Bath, and after that she did social work training at the University of Bath before she went off to be a social worker for a while, working with the NSPCC in Bristol. So she spent a bit of time outside Bath, but only went to Bristol. After that, she came back to the University of Bath to do a master's in social policy analysis, and then did her PhD whilst acting as the director of a research centre at the university. And she got her PhD in 2005. After that, she worked in Bath and got her chair in terms of international social work and innovation in 2019. Besides being the professor that I've described, she is also the Associate Dean for Internationalisation at the university. So I'm going to step back now. Thank you all for coming. Louise, welcome, and take it away.
Well, thank you very much. First of all, thank you very much, David, for the invitation. And thank you all for coming. You're clearly not bakers, as you've decided to come and listen to this instead of watch the Bake Off final. So I'm very impressed by that. Or you've all got it on record, perhaps. So we're used now to delivering lectures online, and I'm sure that you're all used to listening to them or participating in Zoom chats or calls. But it's never the same, and I really regret the fact that we can't all be at the Brisley down in town this evening, as I would have liked nothing more to have come down and met up with you all and be able to stay around and have a chat afterwards. But we're going to have to just make the best of it, I think. If there is anything that you really want to ask while I'm going along, do stop me as we go, or use the chat function, and we can have a conversation and discussion after my presentation. So I'd like to say a little bit more about my background and how I have arrived at the position of researching these topics, which I'm going to share with you tonight. As David has said, I did my social work training at Bath, and I went off to work very fresh-faced as a child protection officer for the NSPCC. And it was a very interesting period of time in the NSPCC, because they were changing over from a very long-standing service where they'd had inspectors that they employed, and we were moving to be called child protection officers. And it was the kind of start of a new, more sort of professional era, really, for that organisation. And they were finding their way a little bit. Up until then, they had very much undertaken inspections in the way that we all think of that historically. When I first joined, we had notebooks like the police, and you could actually claim expenses for shoe leather, for walking your patch. So it was a very much a period of transition that they were going through. And during that time, they moved from investigations to undertaking lots of different new services in the field of child protection. And during that period of time I was there, we did everything from investigations with the police. We did training for judges around how to interview the children in court. We did group work with sex offenders. I was trained in family therapy so that we could work with whole families. And we did a lot of direct work with children. And so it felt as if every year we were doing something new. And the reason I'm telling you this is that it felt after a while as if there was no sense of why we were doing it, or whether we knew what outcomes all of these new services would produce for children, whether we were actually doing good and making a difference. So after a while, I went back to the university because I was interested in the emergence at that time of the whole topic around evidence-based practice. And it was very much a tradition that came from the health service, as some of you may be aware. And it's a sort of concept that's very difficult to argue with. So if we're talking about the development of new services, or changing the services that we provide, or wanting to improve outcomes, then you couldn't really argue with the notion that we should be using services that have an evidence base that demonstrate their effectiveness. And so I was very interested in that whole idea and in the way in which we evaluated social work services. And what I rapidly discovered was that there were very, very few services, social work services in the UK, that actually had any kind of a rigorous or robust evidence base. So we were very much doing what we'd always done and hoped that it would make a difference. And so that kind of caught my attention, really. And I went back to the university to do my master's degree and to train in evaluation skills. And soon after completing that degree, having left the NSPCC, I worked for a number of local authorities, including Avon at the time, which then became Baines, as you know. And the whole debate about developing an evidence base for social work continued to kind of rumble along. There's a lot of support from the Blair government for what they then called What Works. So the whole What Works agenda then sprang out from there. And I thought, well, how are we ever going to develop an evidence base in social work in a context where we're dealing with very vulnerable populations? It's often a very low resource context in which we're practicing. A lot of the public sector funding goes into health, and social work is often the poor relation. And so there was a very small evidence base, and it wasn't growing very rapidly. And I started undertaking at the university one evaluation after another. So we would have a new service that perhaps Wiltshire County Council had set up. We'd be commissioned to evaluate it. And I probably undertook about 15 or 20 of these service evaluations. And I was sitting in my office one day on campus, and a colleague of mine came in, and he threw a book onto my desk, and he said, "You should read this." And it was a book called The Diffusion of Innovation by Everett Rogers, who was an American sociologist, and he'd written this book in the 60s. And it was talking about how to scale up things that are new, something that is innovative. And I thought, that's what we're doing. We're actually developing innovative methods of practice, so innovative models or interventions in social work, and then we're testing them. And so I started to use the theory of innovation to try and understand lots of the issues that we were facing in trying to generate evidence to help promote improvement and change in the services that were delivered. And that's how I arrived at the position I'm in today, where the whole body of work that I now do relates in one way or another to the theory of innovation, and in particular what we now refer to as social innovation. So I'm just going to start sharing my screen with you so that I can run through these slides, and I hope that you can all see those. So please do say, David, if those have not come up. And the title of this presentation this evening is Innovation, the Word That Would Be King. And that's also the title of one of the papers that I've written around social innovation. So I'm hoping now that this will, So what I thought I would do very briefly is just say a little bit about what we mean when we talk about social innovation. So when I refer to that, so we all know what innovation means, and it's defined in the literature as being very different to invention. So invention is the idea, and the innovation is the implementation of that idea, whatever that might be, whether it's Toshiba developing the first laptop or mobile phones and associated products, etc. So we often now think about digital innovation. We talk in social work and social sciences about social innovation, and it refers to the design and implementation of something that might be a product, it might be a process or an organizational change or a new solution, but the difference being it aims to improve the welfare and well-being of individuals and communities. Or it's a new product or process that is new to the area or to the team that are adopting it. So that's when we talk about social innovation, that's what I'm referring to. And the reason that this is has become of great interest in the public sector, so it became attached to that whole what works agenda. And there's a number of reasons why it's of interest to public sector organisations. And a lot of work has been done around comparing, is the process of innovation different in public sector organisations, or can we learn from the private sector? So if we think about introducing an innovative product to market in the private sector, one of the key differences usually is that you're looking to make a profit, or organisations are looking to generate a profit from that. So the difference here is we're looking to generate better outcomes around health and well-being. But it's of interest because we're looking all the time for solutions to what we call, ingrained wicked problems. So, for example, how to reduce the reoffending rates of young offenders, how to promote greater independence amongst an ageing population and to keep people out of residential care, how to prevent child maltreatment. There's lots of kind of really deeply ingrained problems in social work that we're trying to tackle and find new solutions to. It very much fitted alongside the evidence-based practice agenda in the way I've described already. But there's also an expectation with innovation that it will lead to improved services or better outcomes. So you'll have a lot of competition between local authorities who are wanting to develop something that is new and better, and also, is different to other organisations that they sit alongside. People want to be first to do something and try something. But running behind the whole concept of innovation in the public sector is this sense also that you can maximise efficiency and achieve more for less. So a better outcome for perhaps less money. So can we find innovative solutions and ways of working with children and families so that we keep children from entering the care system and becoming looked after children, which is a very expensive part of service that we provide. So can we provide more for less? Can we maximise efficiencies, particularly in a period of austerity when public expenditure is much less? So alongside that, we've also got a context of changing demographics and demand for services, which we're all aware of, an ageing population, a growth in the demand for services, and we're looking all the time at ways of saving money. There are a number of examples that I could have given this evening of innovations, innovative models or interventions in social work practice that have probably been reported on quite a lot in the press and that people will have heard of. So Sure Start was an early years programme that was initially introduced into the UK by Tessa Jowell, actually, and through and Gordon Brown very early on, probably in the late 1990s. We first started to see Sure Start programs setting up. And direct payments is another example of a new innovative service. Direct payments was originally, it's a cash for care scheme. So instead of providing a package of care for people, the idea was that we would give people the equivalent money and they would purchase their own services. And it arose out of the service user movement, and behind that were those principles of choice and empowerment. So direct payments was new, again in the 1990s. Nurse-family partnership is a model of practice that we borrowed from the US. The Troubled Families Program, where we were paying private sector organisations for the results of the work that they were doing with families in local authorities. And another example would be something like the Scared Straight projects, which again was initiated in the United States. And the whole concept of the Scared Straight projects was that you took young people who were at risk of offending, who were on the cusp of going into the criminal justice system, and you would take them into prisons. They would meet people who had been convicted and had spent time in prison, and you basically the idea was that you scared young people away from a life of crime. So what's interesting about all of these examples is that they are all innovative models of practice that have been borrowed from other countries. And the majority of these have come from the US. And we borrow a lot of innovative ideas in social work and social care from Australia and from the US, so from other developed countries. And it was interesting as we started to see the evaluations coming through of these programs, that actually they were costing us a huge amount of money to set up and trial, and yet the outcomes weren't what they should have been. And that's why I've got Mind the Gap on my slide. And this is quite important to me because as we saw the implementation of all of these programs, as they were scaled up and they were rolled out, we spent vast sums of money, which we often don't have in social work, very scarce resources, piloting and then running these programs. In that context of trying to develop an evidence-based portfolio of programs. And whilst trialing all of those new ideas and new programs, we've got teams of social workers and social care staff who are having to deal with the constant change that then requires them to make. And what was really clear from the evidence that was coming out of all of those evaluations, and also from the 20 or more evaluations that I've done of services by then, that the outcomes were rarely as good as when the interventions had moved from one country to another. And Sure Start was a very good example of that. So between 1999 and 2002, we spent £540 million on Sure Start. I mean, that is a huge part of a social work budget nationally. And right from the kickoff, the evaluation results for Sure Start were really poor. And it took until about 2015, and it took various governments a number of times trialing different teams of evaluators and different universities before they started seeing quite small positive gains from the amount of money that they were investing in Sure Start. And that was a similar picture with many of the other initiatives that I've talked about. Things like the direct payments scheme is still running and is now legislated for in the UK. But not only were we seeing poor outcomes from a lot of these innovations that we borrowed from other countries, what we were seeing was a huge resistance from staff, and often a resistance also from the users of those services in terms of the take-up. So the take-up rate, for example, of direct payments has been very, very low compared to what we'd anticipated when we borrowed and transferred the model into the UK. So this was the context in which I was starting out in my career and evaluating all of these new services on behalf of directors of social services who wanted results. They'd spent money and they wanted to know that their new services or their innovation was going to either be more efficient, produce better outcomes, or save money in some way. You know, were the teams that we were working with likely to be able to prevent children going into expensive residential care facilities, for example? And that's a problem that remains to this day. So thinking about Everett's book on the diffusion of innovation, I thought what I was most interested in spending my time doing was trying to see if there was a way forward where we could borrow innovative models that had a proven track record in other countries. Could we transfer them? In fact, people were going to transfer them anyway, but was there a way in which we could bring them into the UK, implement them better, and not have that implementation gap, so that we could produce better outcomes? And could we do that in a low resource context, which is what social work essentially is? And also, as other countries and developing countries were starting to develop social work services and their governments were looking abroad for ideas and borrowing models, could we support the implementation of those models as they moved into other countries in very, very low resource contexts? And I'm going to describe some of those projects that I've been working on I'm going to give you a tour of some of the countries that I've been working in, implementing some of those models and trying to find a better way to support those processes. So that's what I've been doing more or less for the last 15 or 20 years, really. And I don't know whether you'll recognize the picture on the screen, but it's very significant to the work that I do, because one of the things I very quickly realized when we were unpicking the evaluation reports and looking at why these models weren't effective, why were they failing to produce the outcomes in the UK that we'd hoped for, was that the evidence-based movement had got too tight a grip on them. So what was happening was that the whole What Works agenda was promoting a narrative around fidelity. If you want to produce the same outcomes that we saw in Minnesota with the Scared Straight project, for example, or with Sure Start, which was called Head Start in the States, then you must implement the model in exactly the same way that we've been using it in the States. And that proved impossible. So this need to adapt the model, both for the context and for the culture in which it was going to be tried and tested in its second or third site, this was really important. And I was talking at a conference in Chile, and I was explaining this whole issue about innovation and what innovation was to a group an audience of 200 social workers. And I used the example of Velcro, and that's what this picture is of. And Velcro was such a great innovation and has been used now. You know, we have it all on our children's shoes, we have it on our bags, we have it on everything. What an amazing, invention and innovation Velcro has been. And I was describing Velcro, and a hand went up in the audience, and the interpreter said to me, "They have no knowledge of or understanding of the word Velcro. What are you talking about?" And it was completely lost in translation. And even when I tried to describe it, they didn't know what I was talking about. And I thought this is a good example of the importance of contextual and cultural adaptation. And so that's my Velcro problem that I had at that time. But it's a good example of why we need to think about the context in which we're going to be working and practicing. And I'm going to give you 3 examples of how I use the diffusion of innovation theory and how we've been trying to support better implementation as models move. And the first example I'm going to talk about is family group conferencing and the work I've been doing in China since 2014. Family group conferencing originates from New Zealand, and it was first developed for use in Maori communities as a decision-making tool. And it was in reaction to there being high levels of Maori children being taken into the care system. And what the social work departments decided that they would do would be to use a model of practice that would engage and mobilize the community that the children were from. And rather than having decisions made where there were concerns about children and the care that those children were receiving, rather than taking them into the care system, they would facilitate, and the community would facilitate, a meeting of the elders and any family members, any adults who knew the child. They would present the concerns around this child and the family, and the problems within the family, and then they would mobilize the community to come up with solutions to support the family and the children, which didn't involve the children being taken into care. And so family group conferencing, those are the origins of that model of practice. And as a model, it moved very quickly. It wasn't long before it was being trialed and tested in Australia, and then it moved to the US, and it's now used in probably 30 or 40 different countries. And in about 2014, I was invited to China to give a lecture at Sun Yat-sen University which is in Guangzhou, in southern China near Hong Kong. And whilst we were there, the academics said to me, basically, the Chinese government are looking to develop social work services. Have you got any ideas? And I said, what do you mean? They said, well, it's a kind of blank canvas. So, you know, are there any models that you think we could trial here? You know, we've got the same issues that all countries have, child maltreatment, for example. And they were under increasing pressure to respond to a number of very, very high profile child protection cases which had been reported on media. And a number of them they'd received attention where children had been murdered, children had jumped off balconies, etc. There was a lot of concern at that time about the growing prevalence and visibility of child maltreatment in China. Then, I mean, it's always been an issue, but it gains in visibility, just as it does here when we have cases like Baby P in the media. So I said, well, you could have a go at trialing family group conferencing. It's a model that has moved around the world, and before I knew it, we'd set up a project in Guangzhou, and we trialed it there. So what I was able to do was to start thinking about a framework for moving interventions from this time the UK to China, and what we would need to make sure that we had what we call system readiness. So what did we need on the ground there? What were the conditions that would enable this to be successful? And what process did you need to go through in order to implement and develop this new service? This is a nice example of an innovation that has moved around the world and still exists today. So the picture in the top right is of a foundling wheel. These were developed in, actually going back to medieval times, originating in Italy, and they were also known as baby hatches or baby boxes. And they were developed and set in the walls initially of churches, developed to respond to a growing problem of infanticide, where for various reasons and in various countries, children were either being abandoned or murdered. And whilst I was working in Guangzhou in 2014, they said to me, one of the things we are trialing is a new baby hatch. And the picture at the bottom right is the baby hatch in Hubei province. And the picture in the middle is the baby hatch that was opened the couple of months before I got to Guangzhou. And the one I went to see the one in Guangzhou, and it was closed when I was there, because it only opens, the door automatically unlocks from 7 p.m. to 7 a.m. And the idea behind this was that they were experiencing a number of problems, partly as a result of the one-child policy in China, with significant numbers of babies being murdered or abandoned. And there's lots of reasons for that, relating to poverty as well. And so I thought, this is interesting. So we're borrowing an idea from Europe now. Baby hatches still exist in Poland, Germany. We used to have them in the UK, and here they were trialing them for the first time in China. And the one in Guangzhou was only open for a matter of about 6 weeks. And in the first 6 weeks that it opened, in the background there is the children's home. And so it was set outside the gates of the children's home. And what happens is the door automatically opens at night, and you were able to go and place your baby on a heated bed inside, shut the door and run away, because it's actually still illegal to abandon, it's illegal to abandon your children in many countries, including China. And they thought that they would, though, be able to abandon children safely. And in the 2 weeks that I was there, a couple went into the hospital. A baby was born and it had a very serious heart defect. And the hospital said, your child needs an operation. Parents said, we can't afford it. And they said, you have to take your baby home then. And they went from the hospital in a taxi to this baby shelter, and they placed the baby there and ran away. But the father was caught. And he was prosecuted for abandonment of this baby. So there are all sorts of contradictions and tensions going on with the introduction of this new service. And after the first 6 weeks that it had been open, 256 babies had been abandoned in it. And so the Chinese government local government at the province took the decision to close it down. And again, it was another example for me of how you have to carefully manage the borrowing of ideas and innovations from other countries. So that's a little tangent, but it's quite an interesting and relevant one, I think, to the topic. So this is a picture here of the first family group conference that we held in Guangzhou. And as with the Maori communities, there was a concern raised about this child, and the social workers worked with the family, and they brought the family together to have a family group conference. And the family then talked through what the problem was, and members of the family offered support and that had not been previously forthcoming, and they were able to resolve a number of the issues that existed for this child. He was actually about 11, this little boy, and they went on to hold other family group conferences in the area, and some of them were very successful in terms of the support that was then forthcoming from family and other sponsors in the community that they brought together to talk about the concerns. And it was a very different cultural experience, both for the social workers and for families. There was a lot of stigma attached to the receipt of services or to asking for help from other members of the family. And so it was a way of breaking with some of those cultural traditions and allowing some of that support to be forthcoming. So what I'd like to do is to move on to talk about another project which is related to the family group conferencing trials that we've been running in China. So I can't remember who in South Africa, somebody at Stellenbosch University had seen, I think, one of the papers I'd written about the trial of family group conferencing in China, and invited me over, and we were able to secure some resources to set up a research project in the townships around Stellenbosch, which is just outside Cape Town. And we went through the same process that we'd been through in China, but very much learning from the mistakes we'd made there, and looking again at transferring the same model, but this time looking at a very, very different cultural context, and the introduction of the same model, but this time in South Africa and then up in Tanzania. And the pictures here are of Kayamandi, which is the township that runs alongside the main road from Cape Town Airport, if you've ever flown into Cape Town, out to Stellenbosch. And it's an informal settlement, and it has a population of about 25,000. 95% of the population are black, unlike the population of Stellenbosch. It was a very, very different context in which to introduce that model. And so the reason that I'm showing this as a second example is so that you get some sense of the different culture in which we would be trying to set up and run a similar sort of social work service, and how we had to adapt it there was very different to how we had to adapt it to China. And yet we're unable to introduce a model and use the same kind of, hold those levels of fidelity that we would really want to have, because of these being such low resource contexts and the lack of a complete social work service in which to slot some of these new services. So we've been learning a lot about cultural adaptation from these examples. And last year, during lockdown, the group of social workers that I've been working with in Kayamandi, this is a photograph of the part of Kayamandi which is very close to the social work office. This is actually a photograph of the social work office, the Child and Family Welfare Office, and some of the children that they were working with. And the top picture is a part of it's on the edge of Kayamandi, and it's known as Slab Town. And this is an informal settlement, again, of people who live under the bridge. And there's about 500 or 600 people who live in shacks that they've built under the bridge there. And it's an area that I've been working in this year, albeit from my desk in Bath. So I have a partnership with the Social Work Child and Welfare Family Welfare Society in Kayamandi, and with a colleague at Stellenbosch University. And I said to them, you know, how's the family group conferencing going? What are the major issues you're experiencing this year? And they said, we have not been able to think about family group conferencing because of COVID. And that part of the Western Cape was an area which experienced the highest rates of COVID in South Africa. It developed very, very quickly there. And they said, what we need to do is we need to have an intervention that we can use to try and reduce the risk of transmission of COVID. So, not being a public health expert, I thought, well, we could try community group conferencing. So what we did was we took the core components of the family group conferencing model, which we tried and tested in China and in these sites the previous year. And we trained volunteers because we had no resources, they had no resources. So this is real impoverished context that we're working in. And we got the volunteers to work with small areas of the community, and they chose Slabtown under the bridge, families who were living under the bridge, and they brought together members of the community to run what they called a community group conference rather than a family group conference. And they started off by educating them about the risk of COVID and how it's transmitted. And they looked at the very harsh lockdown measures that were being put in place or had been put in place by the South African government, which I don't know whether you can recall, but they were in full lockdown. They had 5 alert levels. They were in full lockdown for many months last year, as we were. They also had rules about social distancing, the closure of schools, the wearing of face coverings, hand sanitizing. But they also prohibited the sale of alcohol and cigarettes, which was an interesting addition to lockdown rules. And the reason for stopping the sale of alcohol was to do with levels of addiction and alcoholism in the townships and in the levels of domestic violence that arose as a direct result of that. The reason for cigarette prohibition was more to do with the government's involvement in the sale of illegal cigarettes, but that's never been publicised. But I know that was part of the reason for that. So it was a very interesting context in which to think about. Okay, so lockdown, we struggled with it in the UK, but if you are a family who are experiencing food poverty and unemployment and just putting a meal on the table is your primary concern, then catching COVID is pretty far down the list. A lot of the families there had no television. They have very little income, so they don't hear the news. They don't put much data onto their mobile phones. They weren't getting much public health information. And there were a lot of myths around the area about how COVID was transmitted or not transmitted. So lockdown in a wealthy, developed country is much easier to manage than lockdown in this context. So that was what they wanted to do. So we trained 6 volunteers. We had 6 projects running in three projects in Kayamandi, 1 at Slabtown, and 3 in Plutersville, which is the coloured township in between Stellenbosch and Kayamandi, but very close geographically. And the volunteers trialled community group conferencing, and this was their focal point. Instead of it being just child welfare, it was the transmission of COVID. They brought the community together, gave them a lot of information, that public health information, and then they came up with solutions. So if I talk a little bit about Slabtown, they came up with their action plan. They held these meetings every week to begin with. They went in and out of lockdown where they weren't able to have meetings. We suspended the project for a couple of months where it was too dangerous to go to host meetings in the community. We had all sorts of challenges. We had a gang murder during the project, so the families all had to stay in because of the safety risks for a couple of weeks. We had power cuts so we couldn't get online and hold our training workshops. All sorts of the volunteers catching COVID, family members dying, a whole array of challenges that had to be overcome. But throughout the whole 12 months, the volunteers kept going and we kept the training going. And the action plans were quite remarkable. They had people who were accessing material to make face coverings. They got hold of supplies of cleaning products that they could use for hand sanitizing, which they distributed to households. They attached the project to a soup kitchen They then developed a community garden where they started growing produce in order to alleviate the problem of feeding families, or at least to try and provide some resources to the community. They set up a project building furniture out of pallets and bits of wood, and were selling some of that furniture and creating a small income from the project. So what had started with family group conferencing had adapted to community group conferencing with a focus on COVID, and had led to all sorts of community developments. So it was a remarkable project for all sorts of reasons. And we're just coming to the end of that. December we'll see the last workshops where we come together with the volunteers to talk about where they go next with that. I'm going to pause because I'm going to tell you about a third project. This is very different. This is a project that I got involved with, and I do want to give credit here, not just for the photographs of these microscopes, but to credit to my colleague Richard Bauman, who works in the physics department at the university, and is I'm in awe of him, and he's quite a genius at what he does. And he was looking for partners in other departments across the campus to take forward the work that he was doing with his 3D printed open flexure microscope. And what Richard does and has done is to produce the software, and which is available on his webpage to anybody who wants to access it. So it's open source software and hardware, all part of the democratization of science movement. And his microscopes are quite small, and they replace, if you can 3D print this microscope and put the lenses in, it replaces the microscopes that labs in Tanzania and other African countries have been using and have had and have received as donations from universities and other parts of the health sector in other countries. So basically what happens is that when we upgrade our equipment here, a lot of this very expensive equipment gets shipped out to Africa. And these 3D printed microscopes are used to identify parasites, including malaria, in blood and water samples. So he uses open source software and hardware. These are affordable now. So when those other large, expensive microscopes break and parts can't be sourced for them, they become redundant. And you've got many of those sitting in labs over there. So Richard's microscope is affordable. It can be made for about £15. They can use locally recycled plastic in the 3D printing process, and it sticks together in a very simplistic way, using the instruction manual that he's developed. So he was interested in how do you scale this up? What do we do with this microscope now we've got it? So how do we customize it, and how can we ensure that the idea will spread and will be used widely across different African countries? So he's been trialing and testing that also in Tanzania. And my role within the project is minimal compared to his as the inventor of his 3D printed microscope. So my role as a social scientist is around implementation and scaling up and understanding the barriers to its use in practice. And we've been we're currently running a research project with one of the main research institutes in Ghana, looking at what are the barriers to its use and how we can overcome some of those. So in just the same way that we looked at the barriers to implementation for Sure Start in the UK, or to family group conferencing in China or in South Africa, we're now using that framework and knowledge in the context of the microscopes. So I thought I'd use that one. There are other examples, but I think it's nice to see that as a contrast. And what have we learned? So context is everything, I believe. So I have major fights at conferences verbally over fidelity versus adaptation. And I'm a great believer that particularly in low resource contexts, we have to be adapting the innovations that we're moving from one site to another, particularly cultural adaptation. It was very interesting very early on with Richard's microscope that the feedback from Tanzania and Ghana was, it's too small. Our fingers are bigger than yours and we can't get them in the microscope. A very simple finding, but one that then leads to Richard understanding that they needs to be able to be customized for use in different sites. Another piece of equipment that worked very well when tested in the labs in the UK didn't work so well when they took it to Africa because of the dust in the environment there. And so they needed to build dust screens around it, etc. So cultural adaptation is really significant. One of the barriers that we come up against a lot when we're moving these innovations around is the risk that organizations have to take. And it's quite difficult to trial and experiment with some of these if you're dealing with vulnerable populations. So it's often a lot easier to trial a new handset or shape of a mobile phone, moving from the pebble to the flat screen, for example, than when you're trialing something in a child protection context where children might die. And so the management of the risk, we all know that risk is a huge element of invention and innovation, but risk has a particular part to play in the process in a social work setting. We've also learned a lot about the need to have appropriate resources. We need champions, we need managers, and we need leadership. And some of those are familiar features of an innovation process in the private sector, but some of them are very particular and need very particular management in a public sector context. But I'm going to stop there. I don't know how long I've spoken for, but I'm going to stop sharing my slides so that perhaps we can come back together in one group and see if there are any questions.
Well, thank you very much, Louise. A very broad talk at the end there. And I must admit, the thing that fascinated me most were your baby boxes.
Yeah.
I'd never heard of these before. But obviously, as you say, they've got a long history. And I was quite surprised, because I've worked in China a lot. And I was quite surprised that the academics you were working with were so open about the problems in society, because normally it's very difficult, even with academics, to get them to be honest about the level of some problems. China's a country which doesn't admit that it's got any problems. And to hear about the number of deaths, suicides, murders, and the number of children dropped off was truly amazing. But anyway, I've got a few questions that have come in. So I hope that there are going to be some more questions. As I said, type them up and send them in to me. So the first one I've got is from Alice. And this is a direct me reading what she writes. So and I presume this is UK government, would government corruption have influenced the effectiveness of social innovation programs such as direct payments from the private sector as well?
Oh,
whether I think that government corruption is a broader term. It doesn't just mean individuals within the government being corrupt. It probably means the way that funding kind of is channeled off to friends and acquaintances. did you have any things being badly or managed?
It's a great question. I would say that what I don't know exactly what's behind Alice's question, but what it makes me think of is what I refer to as the politics of innovation, or the politics of research, if you like, because there is very much we are operating in a landscape and context within which only certain things get funded, and what gets funded is very political. So we know that projects and interventions that the public think are the right things to do will be funded, such as being, tough, Tony Blair's tough on crime, tough on the causes of crime. Whereas if we really addressed the cause of youth offending, and wanted to stop locking so many young people up, we probably wouldn't be running the services that we are. We would be investing our money somewhere else, but it wouldn't be politically acceptable probably to be doing that. So what services get funded, I think, is very political, if that's what Alice means. And what research and evaluations get funded is very political. What questions get asked is very political. Who defines those questions? I was in a really interesting meeting some years ago, we were talking about what services, how to improve mental health services. Essentially, it was. I'm generalising a little bit, and I was in a room with we brought together some service users and service providers, and there was a consultant psychiatrist in the room, and some psychologists and some CPNs and various professionals. And I said, okay, you're going to run this new service. So I said, you want me to evaluate it for you? That's fine. So what are the outcomes that we're looking for? How will we know if it's made a difference? What do you expect it to achieve? What's in the black box? What's the theory of change here? So I like to have that conversation so that we can design the evaluation together. And the consultant psychiatrist said, well, it's symptom reduction. So there are scales that we'll be able to use to measure symptom reduction. And I thought, yeah, we can do that. And the service user said, well, I don't really know what that means, she said, but what I would like is that when I come into the room, the consultant looks up and has eye contact with me. And she said, I'd like the service to improve in that way. And so we've got this vast array of different outcomes that different people and different stakeholders are looking for. And therefore, what gets evaluated and what research questions are asked and what outcome measures you use is very political. I hope that addresses Alice's question in some way.
Yes, Alice has said that she's very pleased with your response.
Okay.
So that's good. I gave her the opportunity to come in and clarify her question,
okay,
but she said she didn't need to.
Okay.
And Mark, I've got your question, which I'm going to come to in a moment. But interestingly, John B, he said very little about defining desired outcomes that can be subsequently measured or can subsequently be measured. Now, you've mentioned that a little bit. I don't know if you want to expand a little bit more on that for John. If not, I'll come back to Mark in a second.
Is his question, or was it a comment that I hadn't said very much about how we were defining the outcomes to measure?
John, do you actually want to unmute and ask your question, please?
Yeah, well, a minute I'd put the question on, you started talking about it. So, but during the talk, I mean, you started off with all these things like Sure Start and so forth, and I was thinking that these are perhaps one of the weaknesses that they'd had was that nobody really had given sufficient thought to what the outcomes were and how they would know how well they were doing at different points in the development. And I thought perhaps that you might have talked about that kind of thing. It's, I suppose, it's a comment really that hadn't been covered in the talk.
Yeah,
I don't know if you want to say anything more.
I haven't said very much. I wanted to give a nice feel this evening, really, to the whole range of sort of innovations that we've been working with. So I haven't said very much about how we then go on to try and develop some evidence base around those and some of the outcomes that we might use. And so we've been evaluating all of these, and we've done quite a lot of work around family group conferencing previously around measuring things, for example, like the size and quality of the network around a child or family. So we can use standardized scales for that, some of the social network instruments that exist. When those projects have been focused on child welfare, we would look at things we would look at things like re-referral rates into social service teams. So a whole host of things, and standardized measures like the Strengths and Difficulties questionnaire, so looking at children's well-being and measuring that. So there's those very sort of hard outcomes like that we can use. We also I would set alongside that more qualitative outcomes, so asking the range of stakeholders involved about the barriers to implementation, for example. So in an ideal world, you'd have two parts to the evaluation. One would be, did it make a difference, and then the other part of the evaluation is, well, if it did or didn't, why did it, and use the qualitative measures to try and explore that. When we're trialing some of these innovations in new sites, what we have to do initially is have a period of time to run a trial, and we wouldn't be able to develop any hard evidence from those. It would very much be more a case of looking at it as an implementation study and the problems, that the inhibitors and facilitators of implementation. And then when we know that it's working and we can try and embed it in the context, we can then try and set up a more robust study. So at different stages of the innovation process, we'd be using different types of evaluation and outcome measures, I think. So I hope that answers the question a bit. I mean, Sure Start had a whole array of measures from physical health, family functioning, maternal well-being, employment, parent-child relationships. They used a whole range of standardized measures to measure its success over the years, and some of those measures were altered and changed over time.
Thank you very much, Louise. Mark, can I ask you to ask your question now, please?
Yes, thank you very much. I very much enjoyed your talk. I have a comment and a question, really. My comment is this. I've spent quite a number of years recently trying to create new services and change services within hospitals. And my experience would be that whilst you can have an idea, a top-down approach to generating change does not work. It needs to be engagement of the people who are going to undertake those changes, and they really need to be involved in the design of those changes as well. So I wonder if that's another sort of facet of talking about the culture so that people feel involved in the service that they're delivering and is relevant to them.
Very much so. Yeah.
My question is about risk. Both what you do and what I do are risky. If someone designs a microscope and says, and the people say they don't like it, well, you can throw it away and start again.
Yeah.
And the concept in business of, the 80-20 concept, that you're allowed to fail 20% of the time, is something that in the kinds of things that we do might prove difficult. And I just wonder how you manage failure with projects?
Well, it's very, very little is written about failure in terms of social innovation. In the last couple of years, we've started to see a little bit more coming through, and for academics and evaluators to be being encouraged to report more on failure now than they were, because that's where a lot of the lessons are for us to take. And very, very little was written about risk. And so that's an area that I've focused on for a couple of years, and thinking about how we manage risk. I think that politically, again, it's very difficult with failure, and that's probably a large part of why we saw Sure Start being invested in over and over again, because otherwise it would have had to have been we might have had to have admitted that it didn't work and it was a failure. So you can keep going until you can produce positive outcomes. You can keep tweaking it, and that's one way to avoid failure. I think that the area in which I work is very, very risk averse. And so it's not often that I see something or have seen something that is trialed in a way where there is any significant risk of it going wrong. And so what we tend to see is a lot of what I call incremental innovation. So small changes being made to existing services or products or processes. Because if we were to do something radical, it would need somebody to really accept responsibility for that risk. And I don't think, particularly in my field of child protection, we're ever likely to see that, because the consequences, not only for service users, but for the organisations, the reputational risk and professional risk are too high. It was interesting when I did the first family group conferencing project. It wasn't overseas, it was in this country. And I worked with a director of children's services who was very much prepared to take risks. And we had a great deal of difficulty seeking support from the Department of Health for the project. We wanted to do a randomised controlled trial. And we worked very closely with all of the organisations in the area, and we wanted to set it up so that in true randomised style, where one group of families had the service and the others had the existing service. And we couldn't get agreement for that from the Department of Health, and so we ended up running a different style of evaluation around that, which then doesn't produce the same rigorous evidence. So we're always kind of balancing, trying to experiment, as you will be aware, with at the same time just trying to get designs through and approved. Really, it's very, very difficult, a very difficult context in which to innovate.
Do you think that's a cultural thing? I mean, if you look in business, this country is said to be more risk averse than, for example, the United States. And I suspect we are in these kinds of service delivery things as well. How often do we export our ideas elsewhere? How often is it that we're importing other people's ideas because they're the ones who have made the primary innovation? That's a question. I don't know the answer.
Not very often.
But perhaps that's telling us something about the way we do things.
Yeah. And yet, yes. And so a lot of the developing countries look here, look to the States, look to Australia to borrow those models, and they are sold to them as evidence-based. And there is a degree of safety, they think, within that. It's been tried and tested in 10 states. There is an evidence base. They've used 3 randomized controlled trials. These are the outcomes they produced. It should be okay. But unless you look at that cultural context and adaptation, I don't think so. One of the things that I did develop through some of the projects was a risk framework where we looked at organizational risk and reputational risk. And risk to individual staff, and we tried to predict what the issues were going to be and to iron them out in advance so that we could try and smooth that path and that implementation process a little bit more. We're a little bit more successful with that, I think. But one of the key barriers is regulation all the time. I mean, the microscope, the Chinese government, you know, and whether they will allow social workers to do X, Y, or Z. You know, the tension with the baby shelters and the abandonment legislation. You know, you come up against that rules and regulation all the time. That's the biggest bane of my life. That's the biggest barrier to innovation in our sectors, I think.
I've got a kind of subsequent question from Francis Duck that I'm going to come to in a moment. What's interesting, though, hearing you talk about these trials, these randomized trials, is how acceptable, in fact, required it is in the pharmaceutical industry.
Mm.
And you're quite prepared to let many hundreds of people not receive the treatment and potentially die or not be cured from the disease to prove the validity of the medicine. You know, that's completely accepted on that front. Yet in other areas, it isn't at all. And I wonder if part of that is because, you know, government is able to say, well, actually, you know, this is the pharmaceutical industry. They're doing this. It's not us. You know, they're trying to bring these medicines to the market. They don't have to worry about the voters saying, you know, we don't like what you're doing, because this is done by a business, a third party. Whereas if it's children in care or other people in care, then that redounds very quickly back onto what the voters are thinking and consequently the risk to government.
Yeah, that context of accountability is very different.
Yeah,
definitely. Yeah.
Okay.
And yet some of those trials, you know, I think also they, you know, when they're written up, they look very neat and tidy. And, you know, if you look at they'll say it was a representative sample of people who took this pill and those took the placebo, and yet you have no idea whether they took it or not. You know, there's no way of telling often. And just in the same, and yet for me in social work, you know, but there is a chance with those clinical trials to develop at least a process that is as rigorous as you can get it. But social work it's such a messy world. Social work, we've got smaller numbers of clinical populations, or the equivalent of our clinical populations are very small. So it's hard to get those large samples. I can remember running a trial in a local authority not so far from here, and we said we needed a sample of 300 people. And I said to them, how long do you think it will take for us to take every referral, and then I'll randomly assign them? We'll have 150 in these two groups. And I said, we have hundreds of referrals. They said 6 months. 18 months later, you know, their data management system for a start is so poor, but 18 months later, we've got 300 people. And then one of the measures is, you know, does this intervention help with your activities of daily living? Can you walk up, and they standardized the measure, can you walk up the stairs? 2/3 of the sample live in a bungalow. So, you know, and then you're pulling your hair out with this design that is just never as neat and tidy and as easy to manage as you think. And those are just kind of anecdotes, but it's difficult.
Well, this is a question from Francis Duck, and it's kind of along the same sort of lines about innovation. So is social innovation planning inherently iterative in practice, i.e. try something, feedback, experience, and then change?
That's the way I think it has to be done in my world. I think there is a stage of the innovation process where that works. And one of the key findings from a number of the studies I've done is that feedback is essential. And if you don't go down the road of the total fidelity and you allow adaptation, then what you're enabled to do is just that. You trial it, you take feedback, and then you alter it and adapt and go again. And that's what we've been doing in South Africa and China. We've had to, because the context is so new and so different, and you have to adapt to. You can't just pick up the model and move it. It has to, and that feedback is essential. As Mark was saying, one of the issues has been quite often around staff resistance, and that was the same in China as it was in the local authorities we worked with in the UK. You know, everybody was on board. The director told them from the top down, you've got to do this, you're going to do it. And then the staff were trained, and yeah, our team's in the pilot. They're all excited and it's all new. And then you do individual interviews with them, which are confidential, and they say to you, we hated it. We didn't want to do it. We liked that team we had before. And you get that resistance and sabotage going on behind the scenes that it's better out in the open, and then you can use some of that. Why is that so difficult? What is it about the resistance? Why are they resisting it? And one of the things that we found from that feedback, Francis, that came through, was that a lot of the innovations were requiring staff to do something different. So it was a slight change of role for them, and they were very uncomfortable with that change. And so we could have, if we'd have known that, or the next time we did it, if we knew that, we could predict that and try and smooth some of that out before we started.
Okay. Louise, there are no more questions coming up, and we're nearly at our finish time anyway. So I would like to thank you for a really interesting talk. You've left me with all sorts of things going around in my head that, you know, are going to be there for a few days, I think, thinking about this. Thank you to all of the people who attended, and particularly to the people who asked questions. It's always great to have some questions because it brings out details that you wouldn't have been able to pick up otherwise. So thank you, Louise. We're going to have a real round of applause. So if you can turn your microphones on, we'll have a genuine thank you very much for your talk. And if you want to have a second bite at this in about a month to 6 weeks' time, I would anticipate that Louise's talk will be on our YouTube channel, so you'll be able to go back and look at it again. So thank you very much, and I'll say good night to everybody.
It was lovely to meet you all, and thank you very much for the questions and for tuning in.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye-bye.